Okay, so today we'll be just quickly having some discussion on diplopia charting. And I have with me Dr. Ruwa Jeswa, who will be the postgraduate, who will be from MNI, who will be presenting the actual diplopia chart interpretations. So before we go on to diplopia chart, just a quick like a revision of how the icrocola muscles work, and that will give us a clue as to how to interpret these diplopia charts in a faster manner. So this is how it looks. Imagine in a diplopia chart, always the right is on your right side. It's as though the patient is seeing. So this will be the right side and this will be the left side. So whenever you are interpreting a diplopia chart, your right is the patient's right and your left is the patient. It's as though you are interpreting it yourself for yourself. So here, this is the right side. You can see that obviously abduction is lateral rectus, adduction is medial rectus. But what is tricky to note is that in abduction, the elevation is superior rectus and depression is inferior rectus. Whereas in adduction, the elevation is inferior oblique and the depression is superior oblique. And the same thing you can see for the left eye also. LR and MR are fairly simple to understand, whereas in abduction, it is the recti that work, superior and inferior. In adduction, it is the opposite, inferior oblique for elevation and superior oblique for depression. And accordingly, these are the nerves that are innervating. So we know that the sixth nerve solely innervates the lateral rectus, whereas the fourth nerve solely innervates the superior oblique, whereas the third nerve innervates the rest of the ocular muscles. So this is something just for revision. Dr. Rua, are you there?
Yes, ma'am.
Yeah, so this was a 60-year-old gentleman with uncontrolled diabetes and horizontal double vision. Can you please interpret the diplopia chart?
Yes, ma'am. So this diplopia chart shows this is an uncrossed diplopia chart with the red, which is the right eye image, being on the right side, and the green, which is the left eye image, being on the left side. So here we can see that the maximum separation is seen in the dextro version in the right side. So this implies that it's something wrong with either the medial rectus or the lateral rectus muscle. So all recti muscles except the lateral rectus produces cross diplopia. So from this chart, it can be inferred that it belongs to a patient with lateral rectus palsy of the right side, probably due to the sixth nerve, which is the abducens nerve palsy of the right eye.
Okay. So here you say that it is a right abducens nerve palsy.
Yes, ma'am.
So do you know what are the, do you know how to perform a diplopia chart?
Yes, ma'am. So diplopia chart at first it's performed using a linear light source with a pair of red and green goggles, with the red goggles being placed over the right eye and the green goggles being placed over the left eye. And the light source is held at a distance of 50 centimeter or 1 meter from the patient. It's preferably performed in a dark room. And patient is given a diplopia chart sheet and color markers based on their interpretation of the light that they perceive.
Okay. And what is the name of the goggles?
Armstrong goggles, ma'am.
Okay. Go on.
Yes, ma'am. So the procedure is then explained to the patient, and then we have the red goggles in the right eye and the green goggles in the left eye. And then in case of vertical, when they complain of vertical separation
Can you
of
limit it
images,
to this particular patient alone? How you would?
ma'am?
Can you limit it to this particular patient alone? How you would have performed? Because this is horizontal.
Yes, ma'am. So this patient, because he complains of horizontal diplopia, so that is why the light is kept vertically. And then we can see the maximum separation, which is seen in dextro version. So
What are the
suggesting
questions you would ask to the patient at each gaze?
like we would ask them how they perceive the image, ma'am. Like we represent their perception of the image in the chart.
Yeah. So ideally, you would say which is the color, like where is the red and where is the green? That would be the question. And how far apart are they?
Yes, ma'am.
What are the important precautions to take before you do this?
Colorblind people need to be excluded from diplopia charting because it doesn't work with them. And like the procedure should be fully explained to the patient, and they should have a clear understanding of how the procedure works.
Okay.
And it's like minor changes cannot be detected through this procedure because it's a quantitative test, and yeah, it's not useful in long-standing cases of nerve palsies.
Or in cases who have suppression or amblyopia, because then they don't see both the images.
Yes, ma'am.
Okay, so congenital palsies also may not be able to do a diplopia testing.
Yes, ma'am.
And another important thing is you'll have to correct the abnormal head posture, because if they continue to have the abnormal head posture, your findings may be different. So it's important to keep them in a forced primary position.
Yes, ma'am.
Okay, Ruwa. Okay, fine. So thank you, Ruwa, for this explanation. So this is an uncrossed binocular diplopia in primary gaze with horizontal separation of images, with the greatest separation being the red in dextroversion. So this is a right lateral rectus or an abducens nerve palsy. So this is a quick tips and tricks that I would like to give for the postgraduates. That is to look for the most deviating color. Here in diplopia charting, you can see clearly that it is the red that is the one that is deviating. So that is the first clue. And when you always explain a diplopia chart, it's important to say red before right, because it's though it is the standard accepted way, you have to mention it that it is red before right. So here, because the red is the one that is deviating the most, it's important to say it is. Then you immediately know the red is the right. So the right eye, whatever is going on in the right eye. The second thing you look for is the gaze of greatest separation. Here again, you can see it is in the dextroversion gaze, and that again gives you a clue that it is when the eye is looking to the right. So when the eye is looking to the right and it is the right eye, which is the muscle that is acting, it is the LR. So you obviously have a clue, and then you can pinpoint. So here it is the right eye that is at fault, and then it is the LR. So you can easily narrow down what is the muscle of choice, muscle that is underacting. So this is for horizontal palsy. Can we move on to the second one? Dr. Rua, can you quickly explain about this diplopia chart?
Yes, ma'am. So here there's a diplopia chart, which again shows an uncrossed diplopia chart with maximum separation being in dextro depression, with the right goggles worn over the right eye and green goggles worn over the left eye. So since the maximum separation is seen in dextro depression, so it's either the muscles which are involved in that movement is the right inferior rectus and the left superior oblique. So here the image which is farthest away, which is more farthest away, is the green, which tells us that it is the left eye which is involved. So this is probably a left superior oblique palsy, which is caused by the palsy of the trochlear nerve.
Okay, and did you mention about anything about the torsional component? Do you think there is a torsional component here?
Yes, ma'am. There is a torsional component here, ma'am. In torsion.
Okay, how do you say it is in torsion?
Because the tilt, ma'am.
Okay.
Of the image.
Okay, so the image is tilted, but remember that it is always the opposite on the eye.
Yes.
So yeah, so here you can call it an uncrossed. And why do you call it an uncrossed?
Because the red is the right image, ma'am. It is.
Though you can see this, you can see the small separation of horizontal here, and here you can still see the red is on the right side.
Yes.
So this is still an uncrossed diplopia in primary gaze, and here is the primary gaze. You can see the horizontal separation clearly. The vertical separation of images. Here what you see is, imagine this is the left eye. If the left eye, if it is straight, you can see that it is tilted inward, right?
Yes.
It looks like it is intorsion, but what is happening in the eye? It is extorsion. Okay. Yeah, it is extorsion, and there is a mild horizontal displacement, and the greatest separation is in dextro depression. Okay.
Yes.
And this is a left superior oblique palsy. Again, some tips and tricks, the same thing. Look for the most deviating color. Here, the green is the deviating color, which means it's the left eye. And look for the gaze of the greatest separation, which is dextro depression. So if it is the left eye and dextro depression, it is the superior oblique, which is an easy way to find out how the separation works. Then easy to pinpoint. And always remember, obliques give uncrossed diplopia and torsion is opposite in the visual field. So these are two things to remember. So here you see the eye, because it's green, it's the left eye. And because it's the dextro depression, it's the superior oblique, left superior oblique. Now, Ruwa, can you please interpret this third one and the last one?
Yes, ma'am. So this diplopia chart, it shows it's a crossed binocular diplopia chart in primary gaze, because the green is on the right side and the red is on the left side. So here there is vertical and also horizontal separation of the images with also a torsional component which can be observed here. And basically the separation in all positions of gaze except in dextroversion. So the muscle which is involved in dextroversion is the lateral rectus. So all muscles except the lateral rectus can be seen involved here.
Which lateral rectus?
The right lateral rectus, ma'am.
Yeah.
So it's probably third nerve palsy of the right side, wherein all muscles except the lateral rectus has been involved.
Okay. When do you keep it vertical? When do you keep it horizontal, the light?
So when the patient complains of vertical separation or vertical diplopia, the light is kept horizontal. And when the patient complains of horizontal diplopia, the light is kept vertical.
Okay, that's good. So this is again just for quick interpretation. It's a cross diplopia because now you see the red is on the other side. The red is on the other side to the green. And there is a vertical as well as a mild horizontal separation. So there is a vertical as well as a horizontal separation. And here now you can see this is the right eye. Now imagine the right eye appears extorted, whereas it's actually the intorsion that is going on. And the greatest separation is actually happening in the red area, which is the right eye in levo version, which is the adduction mode and elevation and depression. So again, you know that there is a small torsional components because the secondary action of the superior rectus and inferior rectus involves torsion. So you will have a little bit of torsional component. And the fact that there is more intorsion shows that the superior rectus may be the more affected one, as is seen here. This is a right oculomotor nerve palsy. Again, it's easy to understand here because this is the red that is the more deviating one. I mean, the red is the more deviating one. So the right eye is at fault, and whichever it is, you can see the separation is more here and least here. So again, it gives you the MR. And again, if you look the IR here, you can see the separation is more, and the SR, again, the separation is the highest. So again, this goes for the easy interpretation. So with this, I think we can open it for more questions. And I just added quickly this photo and I sneaked it in just in time to show our thanks to Dr. Ravi Shankar for this really kind gesture. And it's not just us, a lot of us are here to learn. So I am also a student in one way. Thank you so much.
Thank you. Wonderful. In a short time, you have given an overview of diplopia chatting. Thank you so much, Dr. Nishan. Dr. Shruti Nishan. Yeah, thank you so much. What's the PG's name? I didn't get.
Dr. Rua.
Rua. Dr. Rua. Yeah, maybe a couple of questions. So, which muscles will produce uncrossed diplopia?
So the obliques are said to produce uncrossed diplopia, sir.
Is that all?
And the lateral rectus muscle, sir.
Abductors. If you have, they're all abductors.
Yes.
Obliques are abductors. Only one thing you told is when color vision is not there, you cannot do diplopia charting. Is that right? Or I that's what I heard, isn't it?
The color blind.
Colorblind. That's what colorblind people, you cannot do a diplopia chart.
We cannot do it with the red and green.
You know what? You can put one lens in one eye, right eye, and leave the other without a lens. You will have a difference. That is the way you do it for colorblind people. Just for the benefit of everybody, I thought I'll add. But wonderful teaching, Dr. Shruti. Thank you so much. We have Pati and Dr. Kavita and Madam Basna, Madam. Your comments, Madam?
Yeah, it was a nice presentation. I don't want to add anything more.
Thank you, Madam.
Clear cut, Shruti.
Yes, Madam. Thank you.
Yeah. Madam, Dr. Kavita, Madam.
Yeah, very clear presentation. I think I just have one question for the student. Why is that sixth nerve is more prone for damage?
Because it has the longest intracranial part.
And any other reason?
Sixth nerve. I'm not sure.
It's very near the, it gets compressed near the bone. So that may be a second cause. It's also more prone for microvascular ischemia. So,
okay.
Yeah. The answer is coming on the chat box. Okay, thank you. Dr. Pati? Pati? Okay. For the benefit of everybody, remember when you do diplopia charting, always red before right and left. They will not change. Only in HES it will change. And another thing is Hey, the diplopia charting and the fields are the ones where as the patient sees. Whereas other things you will put, even fundus and all will be as you see. So these are small things, and I think,
Chandru?
yes, Parthi, your comments
Yeah,
on
no
diplopia
questions.
charting.
Shruti was very, very informative, very innovative way of teaching. Very good. Congrats to Shruti, basically.
Hmm.
I think very innovative way of teaching the postgraduates. I
Yeah.
think kudos.